Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins neurosurgeon Daniel Lebelski will be speaking about understanding and treating spinal tumors. Before we get started, we'd like to provide some user tips so that you're comfortable using this platform. The first 30 minutes of our program will include an informative presentation by Dr. Lebelski. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note, if you don't want your name attached to your question, please check Send Anonymously. We'll do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedbacks to hopkinsseminars@jhmi.edu. Please note, this program is being recorded. At the end of the webinar, we'd greatly appreciate receiving your feedback and ask that you complete our survey. Look for it to appear in a pop-up window. And now I'd like to welcome Dr. Lebelski to begin our presentation.
Good morning, and thank you everyone for joining today. My name is Dr. Daniel Lebelski, and I'm the Director of Spine Tumor Surgery at Johns Hopkins. Today, the title of my talk is Understanding and Treating Spinal Tumors. I want to focus on the latest advances in diagnosis, treatment, and patient care. And I want to be clear that this presentation is really designed for the general public, and my goal is to make complex topics as accessible to everyone as possible. So let's start with an overview of what we'll be covering today. First, I want to define what spinal tumors are and their impact. I want to talk about the signs and symptoms. How are these tumors diagnosed and treated? I want to highlight some exciting advancements in research and innovation. And then last, we'll talk about the importance of the patient-centered, multidisciplinary approach to care that we have here at Johns Hopkins. And we will have plenty of time at the end for questions. So what are spinal tumors? Spinal tumors are abnormal growths in or around the spinal cord or vertebral column. There are two main categories of spinal tumors: primary tumors and metastatic tumors. Primary tumors originate in the spine or spinal cord, so they could originate in the vertebral column or inside the dura, intradural, which is inside the sac that houses the spinal cord, or intramedullary, which is inside the spinal cord itself. And then there's metastatic tumors, which typically spread to the vertebrae, to the bones of the spinal column, and they typically spread from other cancers like lung, breast, or prostate. So when talking about primary tumors, you can see this schematic shows where these primary tumors can arise. You can have intradural. So in this schematic, the gray is the spinal cord and the pink is a tumor. So the gray spinal cord can have a tumor inside the spinal cord. It could be, that's called intramedullary. It could be outside the spinal cord, but inside the spinal sac. That's called intradural extramedullary. And then the last one is called extradural, which is outside of the dura. That's outside of the sac of the spinal cord and outside of the spinal cord. And you can see there on the bottom, it's located in the vertebra itself. That typically could either be a primary bony tumor, or it could be a metastasis. And again, here summarizing what we just said. And so what are the different types of primary tumors? When we're talking about intradural, we're typically thinking of meningioma, schwannoma, or neurofibroma, arising from the meninges, or the membrane that makes up the dura, that covering, or schwannoma neurofibroma arising from the nerve sheath. Intramedullary, which is inside the spinal cord, arising from the spinal cord substance itself, is most commonly astrocytoma, ependymoma, or hemangioblastoma. And there's, of course, others, but these are the most common. And then extradural, most commonly metastasis, and more rarely primary bony tumors. And it's important to understand the differences because these tumors present differently and their treatment paradigms are very, very different. even just within intramedullary, for example, an astrocytoma and an ependymoma have very different approaches. One is more heavily weighted on the surgical side, and one is more heavily weighted on the non-surgical side. Same for extradural. When we're talking about metastasis, which is becoming increasingly common as the population ages, 20% of cancer patients will develop spinal metastasis, and that's very, very different in the approach. Is the metastasis eroding the bone? Is it pressing on the spinal cord? Is it just localized within the vertebrae and doesn't need any surgery? And then primary bony tumors as well have a very different approach, which tends to rely heavily on surgical approaches, but will differ based on what type it is. Some are benign, some are more aggressive, some are slow growing, and they all have different pathways. And because the spinal tumors vary so much, the symptoms as well vary depending on their size, their location, and whether or not they are pressing on the nerves or spinal cord. So mild symptoms will often start with persistent back pain, which may worsen over time. Now, I think it's very, very important to recognize that back pain is also exceedingly common in the population. Epidemiological studies show that as much as 80%, 80% of the US population at some time in their life will have to take time off of work from back pain. So back pain in and of itself does not say it's a spinal tumor, but sometimes when it's persistent and worsening, that may be a first indication. Now, as the tumor grows, especially if it's pressing on the spinal cord or the nerves, it may cause weakness or numbness in the arms or legs. And especially when that weakness develops in the arms or legs, that raises red flags for spinal tumor surgeons and physicians to get imaging and evaluate in a timely manner to prevent that weakness from progressing or becoming irreversible. And then when that weakness progresses, it can lead to difficulty walking, and in very severe instances can even lead to loss of bowel or bladder control. And therefore, early detection is critical to prevent these severe outcomes, and early detection leads to early intervention, which gives the best prognosis. And so again, the causes and risk factors, because of how varied spinal tumors are, they also differ by type. Primary tumors may result from genetic mutations or hereditary conditions like neurofibromatosis, whereas metastatic tumors occur when cancer from another part of the body spreads to the spine, which we said earlier can happen in about 20% of cancer patients. Risk factors include having a cancer history, older age, having inherited conditions. And while some risk factors cannot be changed, early screening, especially in higher risk populations, can make a difference. And so diagnosing spinal tumors is driven by imaging. MRI is the gold standard. It gives us very detailed views of the soft tissues, the spinal cord, the nerves, the surrounding muscles. And so that's why the MRI is the best modality to use. We will also use CT scans and X-rays sometimes to visualize bony involvement, particularly when it comes to primary bony tumors, when it comes to patients with metastasis that goes to the bone, that may be eroding bone, maybe causing instability, biomechanical instability. Oftentimes, we'll use a CAT scan or an X-ray, which gives us better visualization of the bony involvement and the bony anatomy. And when imaging suggests a tumor, oftentimes, assuming that it's not someone that's rapidly losing function, we do try to perform a biopsy in order to determine the type of tumor. Determining the type of tumor when it's not readily apparent from the imaging will allow us to then understand and decide what's the best treatment paradigm. And at Johns Hopkins, we're exploring advanced techniques like radiomics and artificial intelligence to enhance diagnostic accuracy. In the future, there may be a way that we can avoid biopsy and avoid other interventions just using advanced imaging platforms. The treatment approach depends on the type of tumor. its location, and the patient's overall health. In the context of neurological dysfunction, surgery is often the first step for removing tumors. Radiation therapy, depending on the tumor type, is often used as an adjunct. It could be used to treat residual tumor cells. It could be used for inoperable cases. And it could be used, especially with stereotactic radiation, it can be used to target tumors and get rid of tumors without needing surgery at all when there is no rapid loss of neurological function or when it's not severely compressing the neurological structures. There's emerging therapies, including immunotherapy and targeted therapies. We're doing next generation sequencing for a lot of tumors. And identifying the molecular abnormalities is showing promise for more and more tumor types, including aggressive tumors. And it's very important to also recognize that a multidisciplinary team, like we have here at Johns Hopkins, ensures that the treatment plan is tailored to each patient's needs. It's not just driven by one specialist, but specialists in all of these areas to help identify the best approach. So what does surgery entail? Surgery can come in lots of different types depending on the tumor type and what's needed. One can pursue decompression, just removing the spinal tumor or decompressing the spinal cord. Or in some contexts, when the spine is unstable, it may need stabilization. In metastasis, in cancer, we'll often do something called separation surgery, where we do a smaller operation just to create room around the spinal cord, and then we target the residual tumor with high-dose radiation, like radiosurgery. In contrast, there's other types of tumors, primary tumors of the bone, sarcomas, chordomas, chondrosarcomas, and such, that require something called an en-bloc surgery. That's a radical surgery that gets rid of the entirety of the tumor with wide margins. That also requires a specialized team with multidisciplinary care and complementary surgical services at times. With advances in imaging and robotics, we're advancing percutaneous and minimally invasive approaches for some types of tumors, where we're able to have smaller incisions, less morbidity, shorter hospital stay, and achieve the same goals. And there's also advances in hardware materials when stabilization is required, whereas titanium is the gold standard for most types of stabilization. Carbon fiber is being increasingly used to help with radiation planning and follow-up. Within the radiation world, I've mentioned stereotactic radiosurgery, but there's the conventional radiation, external beam, and then there's proton beam, which are all available. And engaging with the radiation doctors early on in the course for some types of cancers allows us to provide patients with a tailored approach with which type of radiation is best for a given tumor. In the world of surgical technique, I think there's a lot of very exciting advancements. We spoke about minimally invasive techniques with small incisions, reduced recovery time, and reduced postoperative pain. Robotics allows greater precision and safety, especially in complex cases. And intraoperative imaging, including MRI and CT intraoperatively, as well as ultrasound intraoperatively, can help ensure complete tumor resection when needed. And these innovations are really transforming outcomes for patients. So in addition to robotic surgery, we have tubular surgery, where we could go work through small tubes that hold open the muscle, divide the muscle, rather than having to burn it or destroy the tissue. And the carbon fiber screws we spoke about help reduce artifact on postoperative imaging to improve adjuvant radiation and diagnostics. Tubular comes in lots of different types. There is tubular surgery, which we could work through 18 or 20 millimeter diameter tubes through small incisions that don't disrupt the tissue as much and have reduced pain. And there's also advances in endoscopy, which is even smaller, which, again, for certain types of tumors, using cameras and better imaging quality, lets us have smaller and smaller incisions and faster recovery. This is an example of using ultrasound in surgery through one of our tubular exposures, and we could identify the spinal cord in the center, showing that there is no longer tumor compression around it. This has real-time visualization of tumor boundaries. Here's an example of the robotics in use. You could see that we upload the patient's individual imaging using a CAT scan. We merge it with the patient's anatomy once the patient's on the table. And then we could drive cement into the bone. We could drive screws into bone with great accuracy using small incisions, because the robotic navigation platform, similar to a GPS, lets us provide very targeted approaches. We're using other types of robotics. The first one I showed was a spine robot. This robot is a different type of robot that lets us access cavities where the tumor may extend. So while the tumor may start in the spine, it may extend into the chest cavity, it may extend into the abdominal cavity. And using robotics such as this one, we're able to work with our general surgery, colorectal, thoracic surgery, urology colleagues, depending on the cavity that the tumor extends to, and provide, again, small incisions working within the cavity to remove the tumor without having large exposures like was historically needed. And I mentioned multidisciplinary care as well. At Johns Hopkins, we have one of the largest spine tumor centers in the world. And twice a week, we meet with surgeons of other specialties, oncologists, radiation oncologists, and rehabilitation providers in order to have everyone provide their unique expertise and their input to provide a tailored approach for the patient. So at Johns Hopkins, another big advantage of what we have is the massive research infrastructure, and we are leading cutting-edge research in spinal tumor care. AI, artificial intelligence, and machine learning are being used to improve diagnostics and predict outcomes. Clinical trials are exploring new therapies, including immunotherapy and gene-based therapy. And again, through our multidisciplinary collaborations that I mentioned earlier, we're able to integrate the latest advances into patient care. And this work is truly driving the future of spine tumor treatment. So we have collaboration in key networks. Some of these are US-based networks between multiple institutions, and some of these are international networks that we're able to combine data from multiple institutions and then analyze them in a way to identify what are the comparative effectiveness of different treatments and what are the optimal approaches for a given pathology. We have an amazing biobanking group. Some of the most renowned scientists in the world are here at Johns Hopkins, and we collect tissue and blood both preoperatively and postoperatively in order to identify whether there's circulating tumor DNA, whether there is specific molecular or genetic abnormalities that can help us create targeted treatments that could change the course of the current patient we're treating, as well as future patients. Genomic analyses. We have studies looking at the genomics of chordoma and chondrosarcoma, as well as other tumor types. And these are able to identify markers for prognosis and therapy. And this allows for personalized, individualized treatments based on an individual's genetic data. Beyond the genetic makeup of the tumor, we also have other individualized predictions. At the previous institution I worked at, with Mike Catan, who led the creation of calculator tools for prostate cancer. And then once I started collaborating with him, we were able to apply his approach for prostate cancer to all tumor types, especially tumors of the spine. And by using large amounts of data from the institution, we're able to provide individualized predictions for different types of interventions specific to the tumor type and specific to the person. and this enhances treatment decision-making. Oftentimes we look at a patient and we say, you know, this person is older or younger, this person is healthier or less healthy. They may have variables that make them more or less good candidates for surgery. And if you combine those variables using these types of prediction tools, you can identify what's the best approach and what's the prognosis. So here's one of the papers we put together looking at cervical spine surgery. We did the same thing in the lumbar spine, creating these calculators where you could plug in individual patient data and get outputs. And then we applied this for infection, both in the spine tumor population and other spinal populations. And then the last thing that's really, really exciting is more in the digital realm. One of the studies we're working on is digital phenotyping, whereby we can use smartphone data, which is in almost everyone's pockets, tracking functionality, sociability, activity amounts. And we're seeing that with more and more data available from the phone, we're actually able to sometimes predict when there may be a tumor recurrence or worsening of the tumor burden before the patient even realizes it, just through subtle changes in activity levels. And so again, using this digital phenotype as opposed to the genetic phenotype, we're able to provide comparative effectiveness of different types of interventions for spinal tumor patients. And lastly, I mentioned this in the beginning, use of AI and machine learning in imaging analysis can help expedite diagnosis of tumor type, can get patients into treatment that they need sooner, and can sometimes help avoid other interventions like biopsy by just providing the diagnosis based on imaging analysis. Other things that we're using these types of advanced imaging techniques is for identifying what are the optimal reconstruction techniques. If the spinal tumor has altered the biomechanics of the spine, what is the best approach for reconstruction? How can we assess the bone quality? Again, all from the image that's obtained up front. And so despite the challenges that spinal tumors present, advances in the care and research that we're doing, I think, offer real hope. Over the past years, survival rates have improved, both with better diagnostic tools and better treatment techniques. And it's very, very important to recognize that we focus not just on survival, as maybe historically was the primary consideration, but we're focusing more and more on preserving mobility, preserving quality of life. What is the best treatment to provide a good quality of life to a patient? Sometimes it's not about maximizing overall survival, but finding ways to do smaller operations to maintain someone's ability to ambulate, to move, and to function with good quality of life. I have many, many success stories of patients who underwent surgery at our center and returned to daily life with minimal limitations. A recent 70-year-old man in Western Maryland who came in with metastatic prostate cancer, which was well controlled except for one site in the spine that had eroded that area of the spine. He was someone who worked on his farm. He was very active. Even though he was older, he was still kind of the primary caretaker. And this gentleman came in very distressed, and we were able to just through percutaneous stabilization, a minimally invasive approach of putting screws above and below where the fracture and offload that fractured segment of his vertebra, almost immediately restore his quality of life and his function, his ability to return to doing his work and what he loved. And the stories like that are countless. That was a metastasis story. We have similar stories with patients that come in with severe pain shooting into their legs, that have intradural tumors that we're able to remove the mass with a short hospital stay and get people to enjoy their quality of life again. And so ultimately, you know, the message is clear. With the right care, a multidisciplinary and thoughtful approach, an individualized approach, recovery is possible, improvement of quality of life is the goal, and that's what we often attain. This is one of our recent meetings with our research group. We review studies, molecular markers, and we're constantly thinking about how to improve care. Navigating spinal tumor diagnosis can sometimes feel overwhelming. There are many, many resources available. I think one place to start is through the Johns Hopkins website, which we'll offer some links to. They offer education, financial counseling, access to support groups. There's national organizations like the Spinal Cord Tumor Association, Cancer Care, the National Cancer Institutes, Chordoma Foundation for that type of tumor. A lot of these tumors have individualized foundations and support groups that can help. There's rehabilitation services, physical and occupational therapy that can help patients regain independence. And I think so it's very, very important when these diagnoses arise, you should know you're not alone and that we have resources here to guide you. So as we wrap up, I really want to emphasize the importance of staying informed, spreading awareness of spinal tumors. If you or someone you know is facing a diagnosis, please know that expert care and innovative treatments are available, and that together we can continue to improve outcomes and bring hope to patients and families. This is the number for the Spinal Tumor Center here at Johns Hopkins. We have a link here for images that could be uploaded for review and second opinion. And I'd like to open the floor for questions. Please feel free to ask me anything. No question is too small or too technical, and I'm here to provide as much clarity as possible. So let's discuss. So I have question number 1 here. How do I know if I have found a qualified surgeon and team to treat my spinal tumor? Is there special training or experience I should look for? That's a great question. And I think the way I would answer that is oftentimes if you go to a hospital, a major academic center certainly, or a place that's affiliated with a large cancer center, I think that's a safe bet to start. I think getting second opinions, surgery could be so divergent, and making sure that the tumor that's being treated, if it needs multidisciplinary care and discussion, that's being done is important. Some people do have specialized training. I personally had specialized training being at a big cancer center and then going and doing additional training at other cancer centers. But that's not necessarily needed. So I think asking your surgeon if this is something that they commonly treat, how often they treat this type of spinal tumor, and then getting additional opinions is always a good option. The next question that's here is, do I need to be concerned about my children's risk for developing a spinal tumor? The short answer to that is no. Spinal tumors are very, very rare. A child's risk for developing a spinal tumor is very unlikely unless you have a familial syndrome. So if you or your parents or siblings have a genetic syndrome like neurofibromatosis, where you have multiple tumors that have been taken out, that's someone that should get screened early. If you have a family member that had cancer, that had a spinal tumor from the cancer, or a family member that had one single tumor that was taken out at some point in their life, especially if they were older, likely that person does not have a familial genetic syndrome. And unless the child is showing some concerning symptoms, I wouldn't be too worried about that. Question number 3 is, does Johns Hopkins perform DNA, genetic, molecular, or methylation testing on tumors? Yes. That's a great question and a very important question, and a reason, especially for rarer tumor types, to come to a place like Johns Hopkins or a large cancer center. What we do is intraoperatively, we send tissue to the pathologist, and the pathologist will review it under the microscope and give us a preliminary diagnosis. The next thing they do is they do more advanced staining. That takes 1 to 2 weeks, and we get a diagnosis from that. After that, they take the tissue type, especially for rarer tumors, and we send it for something called next generation sequencing, where we look at genetic, molecular profile of the tumor to help guide targeted care. The last thing we do that not everyone does, that very few places does, is we have research studies where we're using circulating tumor DNA, where we're actually collecting the blood and collecting tissue and analyzing it for circulating tumor DNA to identify the unique individual patient profile. And then we're using that same profile as part of the follow-up and postoperative care to identify the levels of that circulating tumor DNA and see if it's staying stable or rising to help guide follow-up and adjuvant postoperative treatment. The next question is, back pain is a symptom of spinal tumor, but how do you know if your back pain is just that or could be something more? I think that's a very important question that I don't want people thinking that if they have back pain, that could be a spinal tumor. I think what I mentioned during my talk is that back pain is very, very common, and that about 80% of the US population has back pain at some point in their life so severe that they need to take time off from work. The percentage of people that have any sort of back pain in their life probably is close to 100%. And so back pain in and of itself does not necessitate that someone has a spinal tumor. And again, I want to reiterate that spinal tumors are very, very rare. What the reason to get imaging, and the primary care doctor can often drive this, is the back pain continuous? Has it been going on for a very long time? Is it progressively worsening? Is it associated with mechanical changes? So when you sit, there's no back pain, and when you stand and move, there's severe excruciating back pain. Other types of back pain are nighttime back pain that wakes you up at night, even when you're laying, that can potentially raise red flags in your primary care provider to say, let's get imaging and make sure that there's nothing that's going on. Excellent question. Next question is, what is the likelihood of needing rehab services after surgery treatment? Rehab services are often needed for certain types of tumors and for certain types of patients. So when a patient presents with ambulatory dysfunction, difficulty walking, difficulty performing their normal activities of daily living, hand dysfunction, oftentimes, even if the tumor was causing it and the tumor is removed, it takes time for the nerves in the spinal cord to heal, and rehab services are needed. The other reason that rehab services are needed is even if someone does not present with those neurological dysfunctions, but the tumor is so large and requires such a large and massive surgery to remove it, the morbidity and the pain caused by surgery can sometimes benefit from rehab to strengthen the core, strengthen the back, strengthen the muscles postoperatively. There are certain types of tumors in young and healthy patients that aren't very neurologically compromised, where they can have the surgery done and 2 days later go home and not need rehab services. So it's very individualized. Here at Johns Hopkins, what we do after surgery is we have the physical therapists and the occupational therapists see the patients, make assessments and evaluations by speaking with the patient and kind of performing some of those activities and making the assessment for if rehab services are needed, and if so, what type. Next question is, how do you know if a tumor has metastasized? So if you or someone you know has cancer, getting plugged in with an oncology center is very important. And what the oncologists do is they perform routine surveillance imaging. So one way to know if there is a tumor is through the surveillance imaging. The CT scan shows a new mass in a different region of the body, and that prompts to get additional imaging and additional evaluation. Another way to know if a tumor has metastasized is a patient has cancer and all of a sudden they have neurological symptoms, back pain, other symptoms that they did not have before that is continuing, progressive, worsening, that should prompt an evaluation with additional imaging to identify if there is a new lesion, a new mass. What's the risk of nerve damage in surgery? That's a very good question. And I would say this, it depends on the tumor type, but in general, if the surgery is not intended to perform that radical wide margin on block surgery where the plan is to cut nerves and to remove a tumor in one piece, often the chance, for tumor types, the chances could be relatively low in the right expert hands. Your surgeon should share with you the risk of nerve damage in surgery. Different tumor types, depending on how intricately they are involved with neural tissue, will drive what the risk of nerve damage is. So for example, an intramedullary spinal cord tumor, that's a tumor within the spinal cord, just to access the tumor, one needs to split open the spinal cord. So in expert hands, that can be done safely, but just the sheer fact of opening the spinal cord, there will be some amount of neurological symptoms. It could be just sensory, proprioceptive, so understanding sense of self and space, or it could be some weakness. Often that's transient, but that's a real risk. Other tumor types, small nerve sheath tumors, bony tumors, those types of surgeries can be done very, very safely without any nerve damage in the operation. There's always a risk, but some types of tumors have higher risks and some have lower. The next question is, can an EMG rule out spinal tumors for neuropathy, or would spinal MRI still be useful? The gold standard for diagnosing spinal tumors is based on imaging. EMG is electromyography. It lets you know how the wiring is in the nerves of the body. So it could tell me the nerves in the leg are irritated, the nerves in the arms are irritated, but it won't tell me what the cause of that irritation is. So there could be compression from mass, there could be compression from disc herniation, arthritis in the spine, it could be compression of the soft tissue, or it could even be sometimes things like peripheral neuropathy or diabetic neuropathy that causes EMG changes. So I would not typically rely on EMG to rule out or diagnose spinal tumors. Imaging is certainly the gold standard. The next question is, if I have a spinal tumor removed, do I need regular follow-up with my neurosurgeon to make sure it doesn't grow back? The answer for that is almost always. At least for the very, first few years post-operatively, it makes sense to have routine surveillance imaging. In our practice, for most types of tumors, we'll do 3-month follow-up, 6-month follow-up, a year follow-up. And then if it's not regrowing, we'll do it yearly and then go to every other year. And once you get further and further out, assuming there's no regrowth, at some point you could either stop surveillance totally or just very much spread it out. But it's not, but it is important to have surveillance even when the whole tumor was taken out, because there's always a risk of regrowth. But I would speak to your surgeon about the specific tumor type and why or why not to do surveillance imaging. In the cancer population, sometimes that surveillance imaging is done by the oncologist or the radiation oncologist, but having some form of surveillance imaging after surgery is critical. Next question, does benign spinal tumor need to be surgically removed? Excellent question. The answer is oftentimes not. So I have many, many patients that I just follow with imaging every few months or every year. If the mass is causing severe compression on neural elements, that may be one reason. If the tumor is growing, that might be another reason to do surgery. Certainly, if the tumor is causing severe symptoms impacting neurological function, pain, or quality of life, that would be an indication of surgery. However, certain types of benign tumors that are just incidentally identified on an imaging oftentimes can be followed. And we have many, many patients here at Johns Hopkins that are just being followed with routine imaging. Sometimes these tumors don't grow for a long time. And so they don't necessarily require surgery. It's very, very important for me to emphasize that, and that is the presence of tumor does not necessarily require surgery. But again, speak with your surgeon or your doctor about that specific tumor type and why not it would need surgery. What is the downtime after spine tumor surgery and what is recovery like? That's a great question. But again, because spinal tumors come in so many different types, it varies dramatically. So we can have certain types of tumors where the whole tailbone needs to be removed and large spinal fusions and reconstructions are required. And sometimes those can require recovery of 3 months, 6 months, or a year even at times. Then there's other types of tumors, small cancer metastases that we could treat using minimally invasive or tubular techniques, small intradural extramedullary tumors that can be removed quite easily and have patients go home the next day. So it depends on the size of the tumor, the scope of the surgery that's needed, techniques employed, and whether any additional care is needed after surgery. Okay. I think that was our last question for the morning. Thank you, everyone, for being here on our webinar. Again, we have resources on the Johns Hopkins website, a phone number here to call if any additional opinions or evaluations are needed. And everyone have a wonderful day. Take care.